So I was asked to discuss the clinical management and natural history of Alport syndrome, and I am going to focus on the renal aspects of the disease. So as we've heard, the clinical and pathologic features of Alport syndrome result from abnormalities in a type 4 collagen network composed of alpha 3, 4, 5 heterotrimers. And what I'm going to talk today about is diagnosis, renal features, the role of tissue studies in diagnosis, and a little bit on aortic disease, as well as treatment, the current status of treatment, including angiotensin blockade, kidney transplantation, and then very briefly some novel therapeutic approaches. So as you're all aware, people with Alport syndrome develop end-stage renal disease. Essentially 100% of males with Alport syndrome develop end-stage renal disease, or ESRD. But also there is a significant percentage of females who develop ESRD. In this particular study, which was a very large collaborative study in Europe, published in 2003, about 30% of females in this study developed ESRD by age 60, and about 40% by age 80. Some people have questioned these percentages because it's possible they reflect an ascertainment bias, meaning women with less severe disease were lost to follow-up. But whatever the exact number is, the fact is that women with Alport syndrome are at risk for chronic kidney disease and end-stage renal disease. And even in Alport's original paper, although the majority of females live to old age, there was a female who developed uremia. In X-linked Alport syndrome in males, the risk of developing ESRD is about 50% by age 25, but doesn't reach 100% until about age 60 to 70. And why is that? The reason for that range of age at ESRD is the COL4A5 genotype. So mutations that result in truncation of the alpha 5 chain or eliminate the alpha 5 chain result in early ESRD, with almost 100% of affected males reaching ESRD by age 30. On the other hand, missense mutations, and these are mutations where a single amino acid in the alpha 5 chain is altered, the 50% ESRD isn't reached till age 30, and 100% by about age 60. And then splicing mutations are intermediate. Now, the reason that the COL4A5 genotype has this effect on development of ESRD is becoming clearer in recent years. So just to go over again the normal expression of the alpha 3, 4, 5 and the alpha 5, 5, 6 heterotrimers in kidney. In the normal situation, alpha 3, 4, 5 is in the glomerular basement membrane, whereas the alpha 5, 5, 6 is in Bowman's capsule, distal and collecting tubular basement membranes, and also in the basement membrane underlying the epidermis of the skin, or the epidermal basement membrane. And the same is true in thin basement membrane nephropathy due to heterozygous mutations in COL4A3 or COL4A4. In the typical male with a hemizygous mutation COL4A5, X-linked Alport syndrome, the alpha 3, 4, 5 chains are completely missing from the kidney and the alpha 556 chains are also completely missing from the kidney and from the skin. In the typical female who has heterozygous disease, there is patchy loss of the alpha 345 chains in glomerular basement membranes, as well as in Bowman's capsule and epidermal basement membrane. And in the typical patient with autosomal recessive Alport syndrome, again, the alpha 345 chains are completely missing, but the alpha 556 heterotrimers are preserved in Bowman's capsule and distal and collecting tubular basement membrane, as well as in epidermal basement membrane. Now, we've known for a long time that this doesn't hold true in all patients with Alport syndrome. So, approximately 20% of males with X-linked Alport syndrome retain expression of the alpha 345 chains in their glomerular basement membranes, as well as alpha 556 in their epidermal basement membrane. About 30 to 40% of females with X-linked Alport syndrome have normal expression of alpha 345 and alpha 556 in their basement membranes, and about 20% of patients with autosomal recessive Alport syndrome have normal expression of these chains. And this last piece of data was reported by Naito and colleagues at the ASN this year, or just last year. So what is behind the genotype effect on ESRD phenotype? There was a recent paper by Hashimura and colleagues from Japan published in Kidney International just a couple of months ago. And what these investigators did was they compared mutations and phenotype in males with X-linked Alport syndrome whose tissues were negative for the alpha 5 chain of type 4 collagen or positive for the alpha 5 chain of type 4 collagen. And you can see that truncating mutations, so mutations that result in failure to produce a full-length alpha 5 chain, so that would include deletions or mutations leading to a premature stop codon, etc. So most of these patients who were alpha 5 negative had some sort of truncating mutation, although some had missense mutations. Whereas among the alpha 5 positive group, there were no truncating mutations. And then they compared clinical outcomes in these patients based on whether or not their basement membranes expressed the alpha 5 chain of type 4 collagen. And you can see in those patients whose basement membranes were negative for the alpha 5 chain, the mean age of ESRD was about 20, whereas in those who had expression of alpha 5 chain in their basement membranes, the mean age was about 35, and this was statistically significant. In addition, patients who were negative for the alpha 5 chain showed earlier onset of sensory neural deafness than patients whose basement membranes were positive for the alpha 5 chain. And this fits with what we know about the expression of alpha 345 chains in the cochlea, in basement membranes of the cochlea, which perhaps Dominic will be addressing. No. So I'm a nephrologist, not an otolaryngologist, but I do know that the alpha 345 chains are present in several basement membranes in the cochlea, including the stria vascularis, the spiral ligament, and a basement membrane that underlies the organ of Corti. And that in mice with autosomal recessive Alport syndrome and in human males with Alport syndrome, the alpha 345 chains are missing from these basement membranes in the cochlea. And although the exact pathophysiology of hearing loss in Alport syndrome is still uncertain, I have little doubt that it's the inciting event is the absence of the alpha 345 network in those cochlear basement membranes. Similar findings were reported by Laura Masella recently. Laura used staining for the alpha-3 chain instead of the alpha-5 chain, but she was looking at the same thing, which is the alpha-3-4-5 network in GBM. And her findings were very similar to Hashimura's, indicating that patients whose basement membranes were negative for the alpha-3 chain had earlier onset of proteinuria, of chronic kidney disease, which means loss of renal function, sensory neural deafness, and ESRD. So we can build a model whereby the nature of the COL4A5 mutation determines whether or not there's an alpha-5 protein that's capable of forming an alpha-3-4-5 network, and that's primarily what determines the rate of development of end-stage renal disease and sensory neural deafness. There's the possibility of an autosomal dominant form of Alport syndrome has been hypothesized for many years. The reason I show this slide is just to point out that those patients who are said to have autosomal dominant Alport syndrome have a less rapid rate of progression to end-stage renal disease overall than patients with X-linked Alport syndrome. I just wanted to say a few words about hematuria and Alport syndrome for those who may not be familiar with some of the details of hematuria and Alport syndrome. So a couple of groups, including Helen Leapis and Jeff at Wash U, but this is a different paper, were lucky enough to capture a red cell crossing the glomerular basement membrane in a patient with hematuria. And this happens to be a patient with thin basement membrane nephropathy. And you can see that the red blood cell is deformable enough to squeeze its way through a very tiny hole in the glomerular capillary wall. And what these and other investigators have hypothesized is that in patients with hematuria, these ruptures of the glomerular capillary wall may take place in individual glomeruli all over the kidneys, but then these gaps are repaired. But that doesn't eliminate the problem because a gap is created somewhere else. That likely explains why hematuria is constant in men with X-linked Alport syndrome. I've yet to encounter any male or report of any male with X-linked Alport syndrome who didn't have hematuria. But it'll be interesting as next generation sequencing becomes more widespread to see if that kind of phenomenon is shown. Females with X-linked Alport syndrome have about a 95% chance of having hematuria. There are obligate carriers, meaning women who must be heterozygotes because they are descended from a mother or father with proven Alport syndrome and have a child with proven Alport syndrome, but the woman doesn't have symptoms herself. That would be an obligate heterozygote. Asymptomatic obligate heterozygote, and that's about 5% of women with X-linked Alport syndrome. Hematuria is constant in autosomal recessive Alport syndrome. I don't think we know in autosomal dominant Alport syndrome whether hematuria is or isn't constant. But presumably 100% of patients with autosomal dominant Alport syndrome have hematuria. Not all carriers of a heterozygous mutation in COL4A3 or COL4A4 have hematuria, however. So there's a difference between those who actually have a progressive disorder, autosomal dominant Alport syndrome, and those who are carriers of autosomal recessive Alport syndrome. Gross hematuria is not unusual in childhood. Some children come to a nephrologist's attention because they have bloody diapers. There are some children who have nearly constant gross hematuria. And the episodes of gross hematuria tend to decrease in frequency with age, particularly in males, perhaps because as you'll see in a subsequent slide, the glomerular basement membrane undergoes progressive thickening and is probably less susceptible to ruptures. But pediatric nephrologists see a lot of children with hematuria who don't have Alport syndrome. So for a pediatric nephrologist and for an adult nephrologist, while Alport syndrome is in the differential of persistent hematuria, there are many other diseases that have to be considered. And some of the families attending today or viewing this conference may have experienced some frustration with how long it may have taken for a nephrologist to finally make a diagnosis of Alport syndrome. Because there are diseases like IgA nephropathy, for example, that cause a large percentage of, are responsible for a large percentage of children with Alport syndrome, renal biopsy remains an important procedure in the differential diagnosis of Alport syndrome. So this flow diagram was published by Judy Savage and others in an expert review earlier this year. And it describes a very coherent approach to trying to distinguish Alport syndrome from thin basement membrane nephropathy because the presentation of persistent hematuria is the same in both conditions. And I just wanted to point out that often at this point is where a patient will undergo renal biopsy. I think as Frances said in answer to a question she received, as next generation sequencing becomes more widely available, there are going to be a lot of patients with hematuria who have their sequencing done here. And one of the challenges for clinicians is going to be, if you have a patient with hematuria and a mutation is found in COL4A3, 4, or 5, does that mean the diagnosis is Alport syndrome? And can you stop evaluating? Or how do you decide when to go on and do a kidney biopsy, even though you have the genetic information? In Alport syndrome, this is an electron micrograph of the glomerular basement membrane. You can see that, well, if I showed you a normal, a basement membrane from a normal individual, you'd see that this is very thin. This is highly attenuated. Maybe about a half to a third the thickness of normal glomerular basement membrane. As Alport syndrome advances, as Frances and Jeff have shown earlier, the basement membrane undergoes thickening. There's no discrete dense layer in the middle of the basement membrane, what we call the lamina densa. But early in the disease, the foot processes of the podocytes are relatively well preserved. We also get this characteristic scalloping of the epithelial aspect of the glomerular basement membrane. And then in more advanced Alport syndrome, the basement membrane has thickened to 3 or 4 times the thickness of normal glomerular basement membrane. You can see these multiple layers of electron-dense material, and now you can see that the discrete foot processes of the podocytes are gone or disappearing. And what happens to the thickness of the glomerular basement membrane in patients with Alport syndrome is that, as I mentioned earlier, it's thin in early childhood and then undergoes progressive thickening throughout the rest of the patient's life, particularly in affected males. The blue line here shows the normal thickening of the glomerular basement membrane. And then in thin basement membrane nephropathy, the basement membrane remains thin throughout life. And you can see there is a period of time in childhood where the thickness of the basement membrane of Alport patients overlaps that of patients with thin basement membrane nephropathy. And this is one of the reasons that distinguishing those two conditions can be very challenging in children. And it's also a reason why, if we're going to biopsy somebody in a family, we often pick the patient who's older and more likely to show characteristic changes of Alport syndrome. Also, the degree of splitting in the glomerular capillary wall, this layering of the lamina densa into multiple strands, that also increases with age, particularly in males, but less so in females. So often in females, this abnormality is undetectable or is very localized, whereas in males it tends to be diffuse. Proteinuria develops inevitably in males with X-linked Alport syndrome and in most females with X-linked Alport syndrome, and as far as we know, in all patients with autosomal recessive Alport syndrome. Now, these data refer to boys. Most likely, the majority of these boys had X-linked Alport syndrome, but these studies were carried out before the genes for Alport syndrome were identified. And in these studies, proteinuria, which is any dot over this red dotted line, was present in basically all boys over the age of 10. More recently, we've looked at at 45 boys with untreated Alport syndrome, these were boys who were known to have Alport syndrome but not receiving any treatment. And they were recruited into the Alport syndrome registry. And you can see here the measure of proteinuria is called the urine protein creatinine ratio. And anything over 0.2 is abnormal. And you can see there's a lot of boys in the adolescent age group who still have normal urine protein levels. And most likely, this is again an effect of genotype as well as age. So going back to this study published by Hashimura, if patients with alpha-5 negative basement membranes, proteinuria was detected at the age of 4, and those with positive basement membranes at the age of 6. And the urine protein creatinine ratios were also significantly different, while their ages were not significantly different. So most likely, or at least I'd say the evidence we have suggests that it's the COL4A5 genotype that determines the timing of the onset of proteinuria as well as the timing of end-stage renal disease. One of the reasons that people with Alport syndrome develop end-stage renal disease is a phenomenon called interstitial fibrosis. So interstitial fibrosis is a term that describes the replacement of tubules and vessels outside the glomeruli by fibrotic tissue. So it's fibrosis of the tissues external to the glomeruli. And in a study we did in collaboration with Marie-Claire Goubler from Paris, some years ago, we found that a very tight inverse correlation between interstitial fibrosis and creatinine clearance in boys with Alport syndrome. So this function here, VV interstitium over cortex, is a measure of interstitial fibrosis. And anything over 0.2 is abnormal. You can see that boys who had a value less than 0.2 had normal creatinine clearances, which is a measure of kidney function or glomerular filtration rate, whereas boys with an elevated value or interstitial fibrosis had abnormal renal function, and this produced a very significant correlation curve. Also, a VV interstitium / cortex over 0.2 was very unusual under the age of 10 and quite common over the age of 10, suggesting that this period of life when there's little or no interstitial fibrosis is maybe the most opportune treatment time for intervention. The alpha-5, alpha-6 network is also present in smooth muscle basement membranes. This was shown by Bogdan Borza in 2001. And more recently, we looked at an X-linked model of Alport syndrome in mice and found, as we might expect, that the alpha-5, 5-6 network was missing from smooth muscle basement membranes of the aorta. The reason I show this is that there have been some reports of arterial and aortic disease in patients, typically males with Alport syndrome. So the first report was of a ruptured intracranial aneurysm in 2000, and then subsequently a ruptured thoracoabdominal aneurysm in an Alport male and aortic dissection in an Alport male. And all told, there's about 7 cases reported in the literature. Now, ruptured abdominal or abdominal aortic aneurysms, aortic dissection, thoracic aortic aneurysms occur in people with chronic kidney disease. So it's certainly not a phenomenon that's unique to Alport syndrome. What's concerning about these patients is their age, especially patients with abdominal aneurysms. These are rarely seen in the normal population until the 60s, and people reach their 60s and 70s. So I think this is an open question. And the question would be, is Alport syndrome a risk factor for aortic disease such as aortic dissection or aortic aneurysm? And I think it would be potentially a valuable thing to do, since it's easy to non-invasively evaluate the aorta to see if this is a more widespread phenomenon than we realize. And the reason it would be maybe valuable to find out if that's true is that, at least in Marfan syndrome, which, as many of you know, is a genetic condition associated with aortic aneurysm, treatment with angiotensin blockade slows the rate of dilatation of the aortic root. And this has been shown by several groups, and I just chose this slide showing that the rate of change in the aorta is reduced by treatment with losartan, an angiotensin receptor blocker. 5 more minutes. Okay. I have 5 more minutes, and I think I can make it. So I'm switching now to therapy. So Oliver Gross and his colleagues published a paper in the autosomal recessive mouse model back in 2003 showing that the early institution of angiotensin blockade using an angiotensin converting enzyme inhibitor had a profound effect on survival of treated mice, particularly when treatment was begun early in the course of the disease. And Oliver and his colleagues further showed, using fibronectin as a marker of fibrosis, that early treatment was associated with a marked reduction in fibrosis in these animals. Oliver and his colleagues have gone on to show that the early institution of ACE inhibition in sibling pairs with Alport syndrome slows progression to end-stage renal disease. And they've expanded this to the entire European registry to show that early institution of ACE inhibition delays the median age at which ESRD occurs in affected males. A group of us built on these findings to publish recommendations for therapy for Alport syndrome, realizing that this is the best we can do at the present time. We didn't mean to say that this was the end-all and be-all of therapy, but our concern was that while we were waiting for some earth-shattering development in the treatment of Alport syndrome, like the success of stem cell therapy or gene therapy or something else, there were children who were progressing who were not being treated. So we published these treatment recommendations, and in the paper they're much more detailed, but I don't want to take up your time with that. So our recommendation was for angiotensin-converting enzyme inhibitor therapy as initial therapy with add-on therapy using an angiotensin receptor blocker or aldosterone inhibitor with the goal of suppressing proteinuria, using proteinuria as the marker of progression that's easily measured in the clinic. And we recommended initiation of therapy in any child with proteinuria, and to consider therapy in boys or girls with microalbuminuria. That means elevated albumin excretion, or albumin excretion under 200 to 300 milligrams per day. Now, we recommended therapy in those children with microalbuminuria who also had a family history of early ESRD, that means ESRD by the age of 30, or who were known to have a mutation associated with early progression to ESRD. And we can talk maybe at some later point is why don't we recommend treating every child from birth? That's a good question that deserves some discussion. And so to put it in a figure, we recommended that any child with a diagnosis of Alport syndrome who had proteinuria should have therapy. But if the child was eligible for a clinical trial, such as the early PROTECT trial being conducted by Oliver and his colleagues in Germany, that patients should be directed to that trial. I just have a couple more slides and then I'm done. So I just wanted to talk about renal transplantation for a moment. Renal transplantation is typically very successful in patients with Alport syndrome. So a few years back, we reported 2-year graft survival in pediatric transplant recipients. We compared children with Alport syndrome to children with structural disease of the urinary tract, such as obstructive uropathy, where there was little chance of disease recurrence in the transplant. And the Alport patients had very comparable outcomes. And this has been confirmed by Oliver and his colleagues, showing that Alport patients are very similar patients in graft survival compared to other transplanted patients. So Alport patients as a group have the same transplant outcomes as other patients do. But there is a small minority of Alport patients who experience a unique phenomenon that is post-transplant antiglomerular basement membrane nephritis. The first thing to say about this is that it's, fortunately, unusual. It affects probably no more than 3% of transplanted Alport males. It's very unusual in Alport females unless they have autosomal recessive disease. It was first reported in the late 1970s by McCoy and colleagues in San Diego. And for those of you who aren't familiar with it, it's a very severe type of glomerulonephritis or inflammation of the glomeruli that's rapidly progressive and is caused by antibodies to the glomerular basement membrane. And typically leads to graft loss despite aggressive therapy and is very likely to recur in subsequent transplants. The target of the antibodies are usually the alpha-5 chain of type 4 collagen, although occasionally if the patient has autosomal recessive Alport syndrome, the target is the alpha-3 chain. And the epitopes for those patients who develop antibodies to the alpha-5 chain were studied by Bogdan Borza and his colleagues and involve epitopes on the surface of the alpha-5 chain NC1. So finally, I think there are a couple ways to look at therapy. One approach is to suppress fibrosis. Another, that Jeff alluded to, would be to try to modify the glomerular genotype or phenotype. If you look at this list, you'll see that evidence of benefit in humans at this point, in people, is restricted to ACE inhibition and angiotensin receptor blockade. So finally, where do we stand in 2014 from a clinical perspective? Alport syndrome is a treatable cause of end-stage renal disease. I think this is probably, to me, the most important change in our thinking over the last decade or so is this idea that Alport syndrome is treatable. I think up until the last decade, we would all assume there's nothing we could do. ESRD can be delayed by early intervention with angiotensin antagonists in affected males and females. Initiation of therapy while renal function is still normal has the greatest impact on outcome. Therefore, early accurate diagnosis of Alport syndrome is crucial. A current indication for intervention is overt proteinuria, which fortunately occurs prior to renal functional deterioration. Kidney transplantation is typically successful in those who progress to ESRD. Something I didn't mention, but that's very important, is that evaluation of potential living-related donors must be informed by an understanding of Alport syndrome genetics. And finally, we need to develop novel therapies to safely augment angiotensin blockade and prevent ESRD. Thank you.